Okay, so hi everyone. Thank you very much for coming to our last session of this semester. My name is Yi and I'll be your host for tonight's session. Before we start, I'd like to acknowledge the traditional owners of the land on which we meet today. I would also like to pay my respects to the elders past, present, and future, and extend the respect to all Aboriginal and Torres Strait Islander people here today. Tonight, we are very fortunate to have both Dr. Chris Hogan and Dr. Allison Moll, who will join us shortly to talk about the challenges and the future of transfusion medicine in Australia. Dr. Hogan is the Director of Laboratory Hematology at Austin Health, and he oversees services including the hospital blood bank transfusion service and the cryopreservation stem cell facility. He has extensive experience in laboratory hematology and transfusion medicine. He was previously the Principal Medical Officer of the Commonwealth's National Blood Authority and National Director of Pathology Service for the Australian Red Cross Blood Service. Dr. Allison Moll is a clinical and laboratory hematologist at Monash Health and Austin Health. She has a special interest in blood transfusion, focusing on optimizing transfusion practices in patients with myelodysplastic syndromes and transfusion-related quality of life and functional outcomes. Dr. Moll is also interested in promoting research and education in transfusion and hematology supportive care, and is a member of the Australian and New Zealand Society of Blood Transfusion Education Subcommittee. Before we start, I would just like to remind everyone to please fill out our attendance form for your chance to enter the 2 Uber Eats vouchers prize draw at the end of this event. Also, if you have any questions, please feel free to put them in the chat and we'll address them together at the end of the talk. Thank you. So without further ado, I would like to welcome Dr. Hogan to speak first.
Okay.
I'll stop share.
Okay, so I'll share now.
Yep. Yes, please.
So can you see that? Not yet.
Not yet.
Okay. I'll try again. Now can you see that?
Yeah.
Chris.
Okay, I'm going to go into presenter mode. And I want you to tell me if you're seeing one slide or 2 slides.
That's 2 slides.
2, okay, we'll change the mode then. Now you should be just seeing 1 slide.
Yes.
Okay, so look, thank you, Yi, and thank you to the Society for asking me to speak. Yi gave me a very difficult topic to predict the future. So I'll try and predict the future. So I think we'll just go on a journey basically, and we'll just paint the landscape, and that'll tell you a bit about the future. And so in order to understand the future, I think we need to briefly visit the past. So we'll do that first. So good old Hippocrates identified blood as a key element in our life forces. So we probably agree with that. And Jan Swammerdam used the microscope invented by van Leeuwenhoek to be the first person to describe red cells. There was a transfusion. The first description of a proper transfusion was more than 300 years ago between dogs. But the first human transfusion using that device was much more recently in 1840. Braxton Hicks, who was an obstetrician, he thought it was perhaps a good idea to anticoagulate blood, and all his patients died, so that was not so good. So then a world-changing thing was the discovery of the blood group antigens relevant to transfusion safety. Now, most of you probably think these were first discovered by Karl Landsteiner, but they weren't. They were actually discovered by Czechoslovakian pathologist called Jan Jansky, and he called the blood groups 1, 2, 3, and 4. And to this day in Russia, the blood groups are still use the Jansky names, which is quite confusing actually. You don't want to give the wrong number to the wrong person. There are other nomenclature systems that we won't dwell on, but Landsteiner called them A, B, and C, and then later on number C was changed to O, and then two of his students, De Castelli and Sturley, they described the AB blood group. So that's way back then. And then those blood groups became relevant to transfusion safety. So we go right up now then to the first ever heart transplant. So one of the concepts I want you to get across tonight is that transfusion medicine permits a whole lot of other medical care, which would otherwise be basically impossible unless you could give transfusion support. So certain types of surgery, for example, a heart transplant, you just can't contemplate that type of surgery without having the capacity to transfuse. You can't do a bone marrow transplant without transfusing. There's so many types of therapy that where transfusion is not central, but transfusion is permissive. And so that's a key kind of take-home message. However, you may have read about the double tragedy in the 1980s of when HIV and hepatitis C contaminated the blood supply. This particularly affected people with haemophilia who needed clotting factor concentrates. This also changed the perspective of government around the world about the safety of blood or the unsafety of blood. And there were many, many inquiries. You may know the Archer inquiry, the Creever inquiry in Canada. There were haematologists who were sent to prison on the basis of these findings in these commissions on that double whammy of HIV and hepatitis C. So, and then by 1995 were the first experiments with artificial blood. So we'll come back to that in much more detail. So now, in the Australian context, at the moment and progressively, the Australian demographic profile is altering. So you can see on the left there, I don't know, can you see my mouse yet? You can see on the left, this is a typical population age distribution that we see, for example, in the developing world, whereby the younger people form the predominant percentage of the overall population. Whereas in Australia, this demographic is changing shape. And this is a so-called coffin distribution. The country in which this inversion of the traditional demographic pyramid is greatest is Japan. Japan has the greatest proportion of older people in the total population in the world. But so this demographic is changing. And as you know from your studies, older people get diseases more than younger people. And so we've got two things happening at the same time. We've got an aging demographic, which is bringing a burden of disease that needs treatment, which will then require transfusion support. Remember, we talked about transfusion being permissive, but at the same time, you have an inversion of the donor to patient ratio. So in a normal population distribution, you have many younger people who are fit and who can be blood donors for older people who need blood transfusions. Whereas in Australia, we're heading in the exactly polar opposite direction, where we're going to have a shrinking number of more eligible, younger, fit donors who have to support the transfusion needs of a growing and burgeoning older population. So that's a looming crisis. So those diseases which require chronic transfusion support, I've kind of given a list there. Myelodysplasia, which Allison, Dr. Mo might speak about, is a condition of marrow failure, which is a pre-leukemic condition, and that is much more prevalent in older people. And so bone marrow transplantation is a modality of care that and stem cell transplantation that we offer more and more now to older, more frail people than we did before. So apart from, I'll just stop that phone, apart from trauma and surgical reasons for needing more transfusion support in older people, there's also a growing burden of chronic diseases that are rising, and that is also pressurizing the blood supply. So to make things even more complicated, Australia is very pleasingly a multi-ethnic country, and you can see in this sort of country of origin map that the ethnicities of Australian people are very many and varied. Now, what you may not have thought about or appreciated is that the red cell antigenic profiles vary by ethnicity. It's not random. And so when we have to try and match blood to people's antigenic profiles, especially if they develop anti-red cell antibodies in their transfusion care, then we potentially have a problem, because the predominant type of blood donor we have currently in Australia are Caucasoids, whereas we've got a growing representation of other ethnicities as patients who require transfusion. So there's a growing disparity between the phenotypical antigenic profiles of the blood that is available through Caucasian donors, that being different from the range of antigenic phenotypes that we need for people who are from non-Caucasoid ethnicities. So that's another pressure on the blood supply. So you see you've got like a perfect storm. You've got a shrinking donor base as a proportion. You've got an aging demographic. You've got cleverer medicine where we're delivering more aggressive care to older people, generating transfusion requirements. And we've got phenotypic mismatch between our patients and our donors. It's even more troublesome than that, because, for example, as you know, sickle cell disease, which is a very transfusion-dependent disease, that disease is more common in sub-Saharan Africa than in any other parts of the world. So at the same time that we are pleased that we're getting a more multi-ethnic composition in Australia, that multi-ethnicity isn't just bringing antigenic disparity, it's also bringing in a greater prevalence of the very diseases that need transfusion support. So that's another kind of two-edged sword. So you can see there, for example, quite significant differences in antigenic frequencies between African and Caucasian people. And so if you've got an African patient who's got sickle cell disease, you may have trouble getting phenotypically perfectly matched blood. And that'll be a problem if the patient's got an anti-red cell antibodies. We know that patients with sickle cell disease and sickle cell beta thalassemia heterozygotes, they have extremely high rates of red cell alloantibody formation. And so these patients do need highly phenotypically matched red cells. And so this is another challenge. If you want to read more about this, you can read my editorial in April from last month in the MJA. Patients with thalassemia major, especially beta thalassemia major, are surviving better nowadays with very aggressive lifelong transfusion support. These patients also develop complex red cell alloantibodies that require highly phenotypically matched red cells, adding to the challenge. And we know that the better you match the transfusions up front, the less allo antibody formation you get. So there's a strong desire to look for these matched blood donors. Myelodysplasia, this marrow failure disorder of older people, these patients have also a high predilection for allo antibody formation and need phenotypic blood. Dialysis patients, we've got a growing burden of renal disease in Australia. We've got a huge growing burden of dialysis dependency that in particular is affecting Indigenous Australians. And these people also have transfusion dependency. They don't all respond to EPO and iron, and they also develop antibodies. Stem cell transplantation, both peripheral blood progenitor and bone marrow, sometimes cord blood transplants are more and more used as modalities of care for patients who are older. These patients, of course, become transfusion dependent until they engraft. And despite that these patients are heavily immune suppressed, they still have a reasonably high rate of allo antibody formation. In the area of solid organ transplantation, especially renal, but also in stem cell, we now can transplant across the ABO barrier. This produces special and complex transfusion requirements. So you can see here, I've put up an example of a patient who's having a stem cell transplant, and you can see here, this is their blood grouping. So you can see here at the start of the month, at the day 0 of their transplant, they group as blood group O, RHD negative. Then about a month or so later, they've undergone blood group transition, and now they group as blood group A for apple, RHD positive. But what about in the middle of the month? You can see here the medical scientist has written the letters DP, that means a dual population. So they've gone from blood group O to blood group A, but in the middle of the month, when they're halfway through their transplant journey, they have both groups at once. So these patients have very complex transfusion support requirements, and you really need to have coffee to work out what blood to give them, especially in the middle of the month. So there are about 100 million blood donations internationally per annum to support those various medical requirements and including trauma and childbirth. Now, in Australia, we have a very protected and very good quality blood supply with very low rates of transfusion transmissible infection predictive risk. And they're all actually much lower than 1 in a million, but the Red Cross Lifeblood Service quote them in that manner. And those risks are, those actuarial risks are much lower than risks such as being struck by lightning. But the story is a bit more complex than that. In fact, 19% of the world's blood donors provide 47% of the blood. The rich countries, the WHO index level 1 countries in human development index, they collect a lot more blood per capita than do the developing countries. And so there's a distortion. So 76% of all the blood that is available is collected by wealthy countries. And those wealthy countries tend to use the blood for themselves. And those wealthy countries have the money to manage infinitesimally small risks in more and more expensive ways, whereas developing countries do not have the funds and the resources either to collect enough blood nor to manage the risks properly. So you can see there in that snapshot from the WHO Hemovigilance survey recently that there's a whole lot of countries that don't even test for HIV and hepatitis C because they can't afford to. In the developing world, most of the blood is given to women who are having postpartum hemorrhages and pregnancy-related bleeding, and to children who are having malaria and other complications like that. Whereas in a country like Australia, the far and away, the predominant use of the blood supply is in older people developing those diseases that are more prevalent in older age. And so you see there's a disparity of access to blood based on what country you're living in. And there's a disparity of access to safe blood, which is disturbing and unfair. So these days now, we can get more accurate information about the antigenic phenotype of blood by doing genotyping using SNPs for the various alleles that make the various red cell antigens. And these SNPs that we choose have very high penetrance. So we can, although we're measuring the genotype, we can accurately predict the phenotype based on the observed genotype. And these techniques are quite powerful, and you can get a whole battery of complex, in inverted commas, phenotypic information based on the genotype. And so you can produce reports like this, where you can see down there in this column where my mouse is, they're the predicted antigens based on whether or not the SNPs are present. And so these techniques are very useful in patients who need highly selected matched blood, such as patients with sickle cell disease. They're also good in patients who've got various types of immune hemolysis, whereby the anti-red cell antibodies interfere with blood grouping using traditional serological methods. What else is happening in the landscape? Well, there are new therapies that interfere with blood grouping and make our lives a hell. For example, there are anti-CD38 molecules that we use in the treatment of patients with myeloma, drugs such as daratumumab, and they interfere with antibody detection in cross-matching. There are drugs, monoclonal antibodies against CD47 that are used in the treatment of solid tumours, not just hematological malignancies. These drugs are very difficult to deal with in the laboratory. They do not just interfere with red cell antibody detection, they also interfere with red cell antigen determination. So we've got new therapies that are making it very difficult to use traditional serology, and we'll have to rely more and more upon genotyping. We also now do what are called haploidentical transplants, where we give a patient half a match. And so what we like to do for these patients is we try and avoid the patient becoming alloimmunized to the non-identical half of their haploidentical stem cell transplant. And so we have to work out a relevant set of blood donors who are matched for both the patient's own HLA haplotype, but avoid giving them platelets that would make them more likely to make alloantibodies against the non-matched half of their haplotransplant. So I'm just trying to paint the picture of the complexity of transfusion care in 2022. We've got lots of data, of course, that tells us that it's not all about red cells. We need to provide aggressive non-red cell support to patients who are having massive transfusion, massive bleed episodes. The provision of these non-red cell supports provides better mortality outcomes. And there's lots of data based in particular on military experience and penetrating trauma that drives the need for the provision of non-red cell support in massively bleeding patients. We know that being very aggressive with fibrinogen also helps outcome, and so there's a lot of pressure to provide purified fibrinogen concentrates in the near future in Australia. These are not available in Australia for acquired hypofibrinogenemia at the moment. We might just skip over that one. So this is just more and more data that tells us that the aggression of non-red cell support in massively bleeding patients improves outcome, putting more pressure on the blood supply. On the other hand, there are a number of trials that have been conducted over the last 20 years that show that in a range of settings, in intensive care settings, in cardiac settings, in neonatal settings, that we can be a little bit more conservative and wait for the hemoglobin to go a little bit lower before we jump in and transfuse, and we have non-inferiority of outcome. There are a number of more recent examples of trials like that. There's this red cell threshold in patients with AMI study. This is almost counterintuitive, isn't it? You would think in somebody who's got an acute coronary event that you would like to maintain their hemoglobin that little bit higher to deliver oxygen to their myocardium, but you can see that the patients who had a more restrictive red cell transfusion strategy, who were given less, given the blood only when the hemoglobin got a bit lower, they actually did better than the patients who were transfused more liberally in terms of major adverse cardiovascular events. A counterintuitive study, but interestingly informing practice. Likewise, low birth weight infants do better if they have a more restrictive transfusion strategy. The same is true with platelet support in low birth weight. So there are a whole range of trials that are telling us to give more blood in massive transfusion settings, but that we can be a bit more restrictive in red cell semi-elective transfusion settings. Again, I'm just trying to paint the complexity of the contemporary landscape. Okay, there's also a whole lot of literature, especially trauma literature, that is re-examining the benefit or not of giving whole blood. As you know, at the moment, we give component therapy. We give red cells, we give plasma, we give platelet concentrates, we give cryoprecipitate, but there may be properties of whole blood that we poorly understand that seem to give some survival benefits. And you can see there's a trend towards better outcome in the use of whole blood than in component therapy that's also trying to affect practice change. We also have newer modalities to make transfusion decisions. So we have point of care devices that are used in theatre or at the bedside that look at the whole of hemostasis in real time, such as TEG and ROTEM, and that there's a whole literature now about the utility of these devices in transfusion decision making compared with conventional FBE and clotting assays done in the laboratory. And so a lot of the trials are informed by these so-called viscoelastic testing modalities. Right, and so in the past, the approach was to just match for ABO and D, and now we've got a much more complex landscape that I've tried to describe to you. And just to sort of wind up, I just want to mention a few more things that are evolving. So what about non-transfusion approaches to treating conditions that we have more traditionally treated by transfusion? So as you know, in TTP, the patients have a deficiency of the ADAMS13 enzyme, which helps to break up and bust up the large multimers of von Willebrand's factor that incite the microvascular thrombosis that leads to the end organ damage. And so the mainstay of treatment for TTP has been, and still is in a way, fresh frozen plasma used for aggressive plasma exchange. But now there are recombinant molecules of ADAMS13 available. So this is an example of how recombinant DNA technology can reduce the need for transfusion and is a part of the future. What else can we do? We can also try to stimulate the bone marrow to work a bit harder to produce blood cells to obfuscate the need for transfusion. And probably the best, more recent examples of that are in regard to platelet transfusions. So as you know, the megakaryocytes are the precursors in the bone marrow that make our platelets. And we can use drugs like romiplastin and eltrombopag to bind to the receptors on the megakaryocytes and to stimulate the megakaryocytes to make more platelets and reduce the patient's platelet transfusion dependency. What about artificial blood? This has been a long and not very successful journey. So the sort of ideal characteristics of artificial blood I've listed there, and no product that has been invented has satisfied all those requirements. So I don't know if any of you have seen the movie called Abyss. In that movie, there's a scene where they put a mouse into a pink coloured liquid filled with oxygen. That is a fluorocarbon, and these are the molecules that have been used to make artificial blood in the first trials. Now probably up to 20 years ago. That scene was actually real. That mouse was breathing oxygen through the fluorocarbon, and these molecules are elongated carbon fluoride chains, and they've got very strong electronegativity, and they can bind the oxygen, but they don't last very long. They can be packaged into very small particles to deliver oxygen to parts of a tissue that are poorly perfused. So for example, if someone's had a stroke, there can be parts of the brain around the necrotic area that are very poorly perfused, and the fluorocarbons can get into those areas and provide oxygen to them where red cells can't fit. There are a whole stack of different hemoglobin solutions modified from cows and humans that are used. Instead of delivering artificial blood in a cellular way, you can just deliver it as. However, these hemoglobin solutions undergo oxidative changes in the circulation, and they're usually quite toxic to the tissues, and so the technology has not overcome some of these toxicity issues. There are a whole different range of different sizes that you can package these artificial blood substitutes in. A lot of them have very different oxygen dissociation curves than a normal adult hemoglobin has, and that affects their utility. Most of them are mainly useful in the short term, that they're not really suitable as alternatives to chronic red cell transfusion, but that they may have a shorter term utility, for example, in trauma or in a military context. And you can see there's an example of a description of the different trials of hemoglobin-based oxygen carrier blood substitutes and things that have gone wrong with those trials. So at the moment, there's no product that is in routine clinical use. There are also trials in progress to generate normal human red cells using stem cell factories. And these have been quite successful in the quality of the products that they make, but the scaling has been hideously expensive. And so they haven't been very successful for those reasons of scale. Nanotechnology does allow some new ideas for the near future. We might be able to package oxygen and drugs, for that matter, inside little packets that have red cell membrane-like artificial coats around them to disguise them from our immune system. And so probably the most recent technological advances towards artificial blood are in the area of nanotechnology, but nothing concrete yet. We also have other sort of nanotechnology therapies that can also reduce our dependence on plasma. I mentioned in TTP, so now we can give nano fragments to act as decoys in TTP. What about patients with hemophilia? So again, we have a huge disparity of the quality of care between developed countries and non-developed countries. In countries like Australia, there's funded access to high quality factor 8 and factor 9 for haemophiliacs, and including for prophylaxis, where in countries like this, if you've got haemophilia, you're in big trouble. You can hardly get access to it if you have a bleed, yet alone for prophylaxis. There was the tragedy in the 1980s of HIV and hepatitis C in the factor 8 and factor 9 concentrates. Now we have sparing of the blood supply with recombinant factor 8 and factor 9 products. We also have got other strategies to reduce the amount of factor 8 and factor 9 we give. We can modify the molecules to extend their half-life with pegylation, or we can bind them to the FC portions of immunoglobulin to extend their half-life and reduce the need for such intensive product support. We can also use modified antibodies that can jump over the area in the clotting cascade that is dependent on the clotting factor in which the patient is deficient. So we've got sort of strategies to trick the clotting cascade and to reduce the reliance on clotting factor replacement. And there are a whole lot of other molecules in development now that are also ways of reducing our dependency on the blood supply. And then not to mention, to finish now, gene therapy. Patients who have severe haemophilia, they have factor 8 levels of about 1%. You only need to increase the level of factor 8 up to about 10% to change that person's life. You don't have to make, by gene therapy, their factor 8 level normal. And so there are very promising studies using vectors to insert factor 8 genes into these patients, and it changes their life and they no longer need blood products. And the same is true with manipulating the genes in haemophilia, in beta thalassemia, I should say, to reduce their transfusion dependency. And there are also a whole lot of new papers coming out now with gene editing using a special type of enzyme package called Casper9, and we can edit the abnormal genes on the beta globin cluster to remove the sickling mutation. So look, thank you for listening. I just wanted to paint you that complex landscape and show you a range of pressures on the blood supply, especially the aging demographic, the complexity of the transfusion support that we need to offer, but at the same time, some promising and exciting new technologies that may provide relief to the pressure on the blood supply. Thank you for listening.
Thank you so much, Chris. So we'll move on to Dr. Allison Mo. I think she's here already.
Yes, hi.
Oh, hi, Allison. How are you?
Hi, good, thanks. Hi, Chris. Hi, Yi.
Good. I think I talked too long, but it's nice to see you.
Yes, you sure.
Well, thank you so much for coming.
I'll turn my camera off then, Yi.
Yeah.
I'll unshare the screen, actually. Yeah.
Now, Dr. Mo, do you have some slides?
I've got a couple of slides. Shall I share the screen? Just hold on.
Please.
I'll just put it on slideshow. Can you see that on slideshow?
Yeah, I can see it clearly now,
Okay.
Allison.
Okay, great. All right.
And I can hear you clearly, yeah.
Okay, great. I'll make a start then. So thanks for the invitation to speak tonight. So I'm one of the haematologists. I work at the Austin, also at Monash, and I'm also currently doing a PhD on optimizing transfusion practices in patients with myelodysplastic syndrome with Monash University. So I think Chris gave a really comprehensive overview of some really exciting and interesting aspects that might come into play in the future in the transfusion world. And I thought what I might do is just follow on with a bit of a case study and a discussion about myelodysplastic syndromes, which is where my research interest is, just to highlight some of those points and sort of where we're heading towards the future. Let's see if I can progress that. Okay. So as I'm sure you all know, transfusion support is vital in blood cancers. And in fact, Australian as well as international data shows that hematology patients, including those with myelodysplastic syndrome, lymphomas, leukemias, they account for up to 1/3 of all of our total transfused red units in our community. It's a huge amount. And of these, patients with myelodysplastic syndromes, or MDS, use the most number of red cell units. So it's a really big group. And for those of you who may not be familiar with this condition, so MDS is a blood cancer and it results in progressive bone marrow failure. And it actually represents about 1 in 6 of all new blood cancer diagnoses in Australia. The median age of diagnosis of the patients is pretty elderly, so they're about sort of 79 years old, and more than half of them have comorbidities at diagnosis, and many of them have cardiac comorbidities particularly. What happens is that these patients get progressive cytopenia, so their blood counts get progressively lower and lower. And the only curative treatment that we have for this condition is a bone marrow transplant, but being generally elderly and having lots of comorbidities means that many patients, or most patients, really cannot receive this treatment. And so they're really supported with transfusion support, as well as some disease-modifying therapies as well. And in fact, about 50% of these patients will require red cell transfusion, and about 1 in 3 are transfusion dependent. So they come into the hospital, every couple of weeks long term to receive red cells. So chronic transfusion support in these patients can have potential complications. So every time we transfuse a patient, there's always a risk of a transfusion reaction and also transfusion transmitted infections, although that risk of infections is sort of low. There's also risk, particularly in this cohort who have cardiac issues. They might have fluid overload, and that can lead to a condition called TACO, which is transfusion-associated circulatory overload, which is basically acute pulmonary edema and fluid overload in the patient as a result of all of that fluid that you're transfusing. In the long term, because they're getting so many units of red cells, they can also develop iron overload, and that can deposit in various tissues and organs, and in particular can lead to cardiac and liver toxicity in the long term. And in addition to that, because they're receiving so many bags of red cells, there's also a risk of alloimmunization, which is the development of red cell alloantibodies against the foreign donor blood group antigens. And antibodies can lead to transfusion reactions and hemolysis, and also lead to delays in providing appropriate blood for the patient, because it can be quite difficult sometimes for the blood bank to work up these antibodies and identify them and give the patient the correct blood. So there's a lot of issues. However, even though these MDS patients are, chronically transfused, there really, at the moment, isn't very good evidence about the optimal way to transfuse them. And this is sort of something leading in the future, which is gathering interest. Certainly in our Australian National Patient Blood Management Guidelines, and if you haven't seen them, I'd encourage you to go and have a look at those. The guidelines actually state that in these patients who are regularly and chronically transfused, there's no evidence to guide particular hemoglobin thresholds. And I know Chris talked a little bit about sort of lower and high hemoglobin thresholds in different groups. And so for these patients, actually, we don't really know what hemoglobin we should be transfusing them at. There was a really big Cochrane review a couple of years ago where they looked at transfusion thresholds for guiding blood transfusion in different settings. And I think they had like over 30 trials over like 13,000 patients or 20,000 patients, something like that in that Cochrane review, but there were actually zero trials in MDS patients. And most of the trials were in kind of critical care and surgical settings. And so those patients are really quite different to your MDS outpatients who are generally elderly, have comorbidities, and they're coming in as outpatients for like regular chronic transfusions. That's really different to someone who's come in from a car accident or trauma and they're acutely anemic and bleeding. And so even now we don't really know whether we should be transfusing them at liberal or sort of liberal thresholds of higher transfusion thresholds versus restrictive, which are lower transfusion thresholds. And there's a lot of ongoing trials in this space. And the other really interesting data that's come out recently is looking at the stability of the hemoglobin. So there was an observational study which followed MDS patients, and they looked at their hemoglobins over a 1-month period. And the authors found that MDS patients who had a lower variation in the hemoglobin had better quality of life scores and less fatigue, whereas those who had a high variation in the hemoglobin, that bounced around a lot, then they did a bit worse in terms of quality of life. And there was no correlation actually with the mean hemoglobin levels. So now we're looking into, well, is it more looking at the stability of the hemoglobin, which is more important than the actual hemoglobin itself? And then in terms of alloimmunization, so patients with MDS, about 30% plus of them will develop a red cell alloantibody, which is a really high percentage. And as I said before, alloimmunization leads to all these problems such as hemolysis, transfusion reactions, and can be quite challenging to provide the appropriate blood for them. And so there's been a lot of interest recently into whether providing better matched blood for these patients is a solution. So, I mean, we can phenotype patients' red cells where we find out what blood groups or what red cell antigens are on their own red cells and try and match that with the donor blood. And increasingly, there's availability now of genotyping of red cells, which is really fantastic, so that we can sort of get a better idea of how to better match these patients' blood. So this is just an example of, I guess, heading in the future, what some transfusion trials might look like. This is actually a trial that I'm involved with as part of my PhD. It's an MDS transfusion trial called REDS2, and it's a pilot study looking at the transfusion of weekly matched red cells in patients with MDS. So with the trial, we're asking the questions, well, first of all, if we transfuse people a bit more frequently, so weekly, we're giving them lower dose. So instead of 4 units of red cells every month, maybe if we give them 1 unit every week, will that make the hemoglobin more stable, improve their quality of life? And is that even feasible? Because that's obviously quite different from the current practice. And then the other question is that, as you probably know, when patients come in for a transfusion at the moment, they need to have a group and antibody screen done 72 hours pre-transfusion. So if we're transfusing people weekly and they have to come in 72 hours pre-transfusion for their group and screen, then that's not very practical, not very feasible. So to facilitate weekly transfusion, we're actually giving them extended matched red blood cells based on their red cell phenotype or genotype. So we don't have to wait around for their pre-transfusion screening results. And obviously, then that's quite novel as well. And we're also looking at sort of quality of life and physical functional tools. And we're also looking to individualize and personalize transfusion, which I think is what's going to happen in the future. So with our pilot study, it's what we call an N of 1 study, which means that we're basically individualizing the protocol for each patient so that they're all a little bit different in terms of what dose of red cell they get, what kind of red cells they get. And so that's really personalizing the transfusion for them. And we're also doing some qualitative studies and interviews as part of that process as well. And the overall aim of the study is to inform a larger randomized trial to compare the different strategies. And there really is a lot of interest in this area. We're leading this at Monash, but we're collaborating with the UK, the NHS, various hospitals there, as well as some hospitals in the Netherlands as well. So there is international interest in this area. So at the moment, what we think currently happens is that a lot of hematologists follow what we call the restrictive transfusion strategy, where we're using lower hemoglobin thresholds. And we actually did a survey of over 100 Australian New Zealand hematologists and found that most of them did do this. And they often transfuse sort of multiple units every couple of weeks. So this is what currently happens with patients. They have a blood test 72 hours pre-transfusion. Someone checks their hemoglobin, then they book them into a day unit. And then the blood bank receives the blood group and screen. They check for new antibodies. Then patient comes in on the day of transfusion. Red cells are requested from blood bank, they're transfused, patient is monitored for transfusion reactions, and then they go home. But there's a lot of areas where there's potential delays. So for example, the patient might have some logistical problem getting the blood test. They're elderly, they might rely on some carers or family members to get them to a pathology collection centre. There could be delays in the clinician checking the results, or delays in trying to book all these patients into busy hospital units. If new antibodies are suspected, this could take hours, sometimes even days to test. On the day of transfusion, if there's some special product that might be required, then that might take a bit longer. And then obviously if the patient has a transfusion reaction or any fluid overload, then there would be some delay and they'd have to stay for a bit longer in hospital. And the patient typically spends sort of 4 to 6 hours in hospital on their day of transfusion. And so that's the current practice. But what we're, and basically it just happens sort of again and again every couple of weeks. Oops. So what we're really doing is trying to cut out some of these processes. So cut out the 72-hour pre-transfusion testing. And also potentially because we're giving matched blood and the hospital blood bank knows in advance that the patient's coming in every week, then they're much more prepared for it. They'll have the matched blood on site, and so there might be less delay in providing the blood products. And in addition, if we're transfusing 1 unit at a time, that might reduce the risk of fluid overload because you're giving less fluid at a time, and potentially giving matched red cells might also reduce the incidence of alloantibody formation and therefore transfusion reaction. So that's what sort of we're doing with this trial, and you know, that could be something that we're doing in the future. And so on the day of transfusion, what happens is the patient comes in, they have their matched red cells, which are pre-requested from the blood bank. And then they have a cannula inserted and some blood taken, and that antibody screen will inform the following week's transfusion, but they don't have to wait around for that, and they just have a small number of units of red cells transfused, they monitor and they go home, and potentially might reduce the hospital visit time. So that was just a bit of an example of a clinical trial where we're trying to change the way that we currently do things to try and improve transfusion in the future. The other, and Chris mentioned, I think, some non sort of blood transfusion alternatives. And so you might have heard of in MDS, luspatercept and other erythroid maturation agents, and they're really exciting as well. They could potentially reduce or even eliminate the need for transfusions in MDS patients in the future. So luspatercept, for those who may not be familiar, is a TGF-beta inhibitor. And what happens is that in patients with myelodysplastic syndromes, as well as in patients with thalassemia major, there's actually some intracellular signaling pathways which are upregulated, which result in ineffective erythropoiesis in these patients. And so luspatercept is a medication which blocks some of that intracellular signaling so that it promotes erythroid maturation in these patients. And it was actually first I guess, explored in patients with thalassemia major, and there have been some major trials there which does show that it reduces transfusion requirements in those patients. And so recently there's been a lot of interest in using it for patients with MDS. So this is the Medalist trial, which was a really pivotal trial, which basically showed that there were patients which randomized MDS patients to luspatercept or placebo, and found that patients who received luspatercept had higher rates of transfusion independence compared to placebo. And on the right there, you can see a graph which shows luspatercept patients had higher hemoglobin levels throughout the trial. So it's a really important trial, and even in Australia now, we have a current clinical trial which is looking at sort of luspatercept in MDS patients. And I guess some further research questions in the future would include, well, what's the impact on quality of life? Because patients, if they're able to stay at home for longer, not coming for transfusion, then you'd hope that means they have improved quality of life. And also, what are the health economics implications? I mean, we also need a lot of baseline information about the cost of transfusion in MDS patients, just as a bit of comparison. We don't have any current data on that, so that's another project that we're working on. For instance, there was a study in thalassemia patients which showed that the total cost per red cell units transfused in one Australian centre was was more than twice the amount that's sort of listed on the bag of blood. So some really important questions to do with health and economics in that area. And finally, in the future, I think we might have other ways of measuring the effectiveness of transfusions. So at the moment, we just check a hemoglobin, you know, what is the patient incremented to, and see if, you know, if you're happy with that. But is that really the best way? So in MDS patients, for instance, quality of life and physical function is really important, but that's not really commonly reported at the moment in clinical trials. And there's certainly a lot of interest in the use of wearable devices and technologies to monitor for the effects of anemia and what happens after transfusion. So for instance, even things like Fitbits, Apple smartwatches, you know, things like that, that can track things like like heart rate, activity levels, we're really using them increasingly now to try and see, oh, can those things actually predict whether a patient needs transfusion rather than just relying on a hemoglobin alone. So I'll leave it there because I think it is